Okay, hi guys, I'm back again. So Sarah Mize here. We're just going to be talking about toxicology today. So let's get started. All right, so obviously when we're talking about toxicology, we're talking about poisoning, essentially, which is the physiological state produced by a poison or other toxic substances. Now, all substances have the potential to be a poison. Polypharmacy overdose is really common, and that's an important thing, and we'll talk a bit more about it, but it often complicates the clinical picture and can make it, can give you a lot more sort of management challenges along the way. So our objectives today, so we're going to go through a bit about toxicology, approach to the assessment of the poison patient. We'll talk about toxidromes, and then we'll talk about another bunch of other different sorts of overdoses and management principles for different things. So just a little bit of epidemiology. So from this is from 2015, and it's from the Poisons Info Centre phone calls. So in 2015, the Poisons Info Centre received over 200,000 phone calls about poisonings. Over 170,000 calls were related to 164,000 total poison exposure events. 64.4 were unintentional, about 8% were medication error, and about 10% were deliberate self-poisoning. Now the age ranges, so these are the big age ranges, so I mean it's quite broad, the 20 to 74-year-olds, they accounted for 40%, and the 1 to 4-year-olds account for 36%, so they're the two biggest age ranges. Substances, some of the biggest ones are household cleaners, and paracetamol-containing analgesics are quite common. Now, self-poisoning and hospital referral were the most common in the adolescent age group. So that's obviously our deliberate overdoses. Now, adults in that 20 to 74-year-old age group, psychotropic pharmaceuticals were the most common, or painkillers is the second most common. And adults over 74, it's typically due to medication errors, and some of those can be quite dangerous, which we will discuss. So poisoning can be, obviously it can be an intentional thing, so it can be a deliberate self-poisoning, an overdose. It can be a malicious sort of third-party poisoning. It can obviously be accidental, so occupational, domestic medication errors, prescription medications with a narrow therapeutic index, so like digoxin, which we'll talk about, and then it can obviously be recreational drugs. So there's different routes of entry into the body, ingestion, which is the most common, so swallowing, inhalation, or smoking, vaping, things like that, injection, and absorption through the skin. So in terms of your clinical approach, initial stabilization is really important. So no matter what you go to, the first thing to do is do your primary survey. If there's things that you need to find and fix, then you need to do that. So if they have airway compromise, you need to manage that. If they have respiratory compromise, you need to manage their breathing with either breathing, ventilation, oxygen, etc. If they have circulatory collapse, you need to manage that. Toxidrome recognition. So we're going to talk about toxidromes and the important ones that you need to be able to recognize. Recognition is important for a couple of things. One, recognition for the importance of urgent transport to hospital. Two is recognizing the ones that may benefit from decontamination then and there. And three is recognizing the ones that there might be treatment out there for which a CCP might be able to help you. We'll talk a little bit about some of the antidotes, and then supportive care. So this is basically your sort of work through list with poisonings. Like I said, the main thing is finding things and treating them, but some poisonings are more likely to have certain signs or symptoms. So stabilization, obviously we're going to do our doctor's ABC. So danger, so obviously to ourselves, others, and the patient may still be in the environment, and it's always important to remove them from the environment. It's important to try and understand how the patient was contaminated. Have they inhaled something? Is it something like organophosphate poisoning and they've got it all over their skin? Is it, those sorts of things are important things to try and work out. And then obviously toxic environments. If you find someone, or someone was found inside a building structure and you think they've been poisoned by some sort of substance, the most important thing is to get them outside. Obviously that's good for them, but it's also good for you. Now, physical things as well. Some of these sort of toxicology things make people quite aggressive and agitated, and so you're at risk of getting injured yourself, as are bystanders, and that's important to be aware of. Now, we will talk about in some of these where this can happen, certain medications should be avoided. So depending on the service you're working in, there's obviously midazolam, which is less commonly used for sedation now that we have options such as droperidol and ketamine. But there are certain situations, for example, where you don't want to be using droperidol for poison patients. Then obviously our response, so you want to establish the conscious level. It helps you to decide how urgent things are, how much assistance you need, etc., etc. It also helps guide your risk assessment. So airway. So you can obviously lose airway reflexes, you can lose your gag reflex, as we all know about. You can get burns to the airway, so things like some of the corrosive agents and things like that may actually cause airway burns. So that's important to know, because then you need to consider it like any other airway burn where they need early intubation. Now, breathing. So obviously you want to assess their breathing status, you want to intervene if need be, oxygen as you need it, do they need IPPV, IPPV, etc. So with their circulation, you want to assess their perfusion status. Are they tachycardic, bradycardic? Are they hypotensive, hypertensive? And are either of these to the point where they need management? So, some people may be bradycardic, but it's at a rate of 40 and they're talking to you and that's fine, but they may be bradycardic at a rate of 20 and that's quite different. Obviously monitoring cardiac monitoring and getting an ECG, because that will give you an indication of if there's any arrhythmias at all. This sort of information also guides your, I guess, whether you need more assistance, do you need IV access, do you need fluids, do you need backup, do you need help? Now, other things, so lots of poisonings lower the seizure threshold, and some are a proconvulsant, so they make you more susceptible or make you more likely to seize. Seizures may also be induced by hypoxia or hypotension, so you just need to manage those as you would a normal seizure. Hypoglycemia, so it's important in all possible poisonings to take a BSL. Some of them, particularly things like insulin and your hypoglycemic agents, will cause hypoglycemia, but other things that you don't necessarily expect to, like beta blockers, will cause hypoglycemia. And control hypothermia, so particularly something over sort of above like the 39.5 mark, we probably want to look at the possibility of active cooling. Definitely if someone's over 40 degrees and you're suspected of poisoning or overdose or whatever, then you need to attempt to actively cool. You can do some simple measures, so you can do trying to remove some of their clothing. You can put cold compresses in the axilla and the groin. You can pop the air conditioning on in the vehicle and put some fluids on them. If you've got cold fluids, you can use them. So there's lots of different options, but trying to somewhat control the hypothermia if it's really high is a good idea. Now, decontamination, resuscitation takes precedence, but some things are more important than others. As we'll talk about things like organophosphate poisoning, where it is often absorbed through the skin, it's often accidental poisoning from farm workers, then they need to be decontaminated. So you need to make sure you remove their clothing, wash their skin with soap and water as best you can, and it may just be a really quick job, and that is totally okay, but you might be able to reduce some of their, because they will have ongoing absorption of that agent if you don't decontaminate. For some things you might just rinse their mouth with water, and the main thing is for yourself trying to make sure you wear enough PPE. If you're ever unsure about things, always contact Poison's information. So antidotes, so we've obviously got naloxone for opioids, glucagon can be used, and high-dose insulin for beta blocker and calcium channel blockers. We've got atropine for organophosphates, digibind for digoxin, there's things like NAC for paracetamol, flumazenil for benzos. Okay, so risk assessment. So these are the things that we want to know. So we obviously want to get a history as best we can, whether that comes from the patient or bystanders or family members. We want to know the agents involved, so what medications, what drugs, how much, if anyone knows. A big thing with prescription medication or even non-prescription medication box overdoses is trying to find all the empty pill packets. So, you know, sometimes you might want to look in the bin and you might find 50 empty packets of paracetamol. We don't always know. So, for example, sometimes you might have a child and the parent says, I had this medication and the box was half full, and now there's definitely some missing, but I don't know how many. So you won't always necessarily know how many are missing, but it's good to just give you a bit of an idea. So like I say, the agents and the doses, so try and calculate as best you can. It's better to overestimate than underestimate, because that will help guide management, and if we are a bit more wary, that's better than not suspecting that anything's going to happen and then something bad does happen. So for example, the packets of paracetamol, you know, if say for example there was 50 sheets and they were sheets of 10, so that gives you, say it's 50 tablets, 500 milligrams, so you add all that up, and then you can use that when you contact Poison's info and tell them exactly how many tablets they've taken. The other thing to be aware of and to keep note of is XR or slow release tablets. As I've written at the bottom, collect everything, all the empty stuff, just bring it all with you to hospital. Time since ingestion is important, and some overdoses are staggered overdoses and happen over a couple of days or a couple of hours or things like that. So that's important to know as well. So Poison's info. All I've written is if unsure, call. I think that's all I've written. Oh, here we go. So this is absolutely your best resource in a poison patient. I would recommend calling them anytime, even if you are strapped for hands. Get a bystander to make the phone call and then put it up next to your ear. The information that these people give you is fantastic, and they will be able to give you a lot of really good advice, even if it's things that you aren't sure of. So I use this all the time, even when I'm in a hospital and it's, you know, anything from a massive paracetamol overdose to a beta blocker overdose to a patient, you know, a child that's come in that has taken 3 of mum's tablets. You know, if you call them, you know, they ask you a bunch of details, but they basically ask you for the patient's age, weight if you know it. They'll ask you how much and what they've taken and what their symptoms are. So like I say, even if you have someone really sick, if you call them and say, this is what they've taken, these are their symptoms right now, we are paramedics, we're pre-hospital, we're trying to get them ready to go to hospital, is there anything else I should do right now? They will give you advice. The people who answer the phone call are not toxicologists, but they have lots of really good information. But if they are ever unsure, they can contact the toxicologist. So there are always toxicologists on call, and they will get them on the phone for you if they think you need them, and they will help you. So that's an invaluable resource that I would definitely recommend using anytime. It also potentially, for some things, may mean the patient doesn't need to go to hospital. There are things like, the little um, toilet bowl sort of things that you put in the toilet bowl to keep your toilet bowl clean. Lots of kids try to eat them, and they're non-toxic, and they get phone calls about it all the time, and they will say they're absolutely fine, they don't need to go to hospital. Or they'll tell you, yes, they need to be in hospital, they need 6 hours of monitoring, or they need this active treatment. So, as I say, they're an invaluable resource, and I would recommend just calling them no matter what. Okay. So, our toxidromes. So, a toxidrome is a group of examination findings, so signs and symptoms that may suggest the pharmacology behind a person's clinical presentation. So, the common toxidromes, which are the ones we're going to talk about, are cholinergic, anticholinergic, sympathomimetic, opioid, and serotonin. So, the cholinergic toxidrome. So, cholinergic toxidrome reflects the acute phase of anticholinesterase poisoning. It's a result of inhibition of the enzyme acetylcholinesterase, which normally breaks down the neurotransmitter acetylcholine. The end result is a buildup of excess level of the neurotransmitter. So we're going to talk a little bit about this because I know it's a bit confusing. So again, as I said in the previous lecture I did, I'm not sure of your exact background or how much of this you remember or don't remember, but just try and stick with me. So normal ACH, so acetylcholine, so it's a neurotransmitter. It's found in lots of areas in the body, and we'll talk a bit more about them in a minute. So you get release at the neuromuscular junction, and it binds to the muscle fiber receptors, which triggers muscle contraction. It's released within the autonomic nervous system, so you get the as well, which is parasympathetic response, rest and digest. So acetylcholine works in many different parts of the body. It's not just one thing or the other. It's stored in vesicles in the axon terminal until it's released via exocytosis. Activates a postsynaptic cell by binding to the receptors. Now there's nicotinic and muscarinic receptors, which becomes important soon. Now we need the acetylcholine to continuously be removed from the synapse, otherwise you get overstimulation, which leads to fatal convulsions, seizures, and paralysis. So the acetylcholine gets broken down by acetylcholinesterase, and then parts of it get reabsorbed back up into the axon terminal. So this is a picture of it. So you've got your acetylcholine, so that comes out, gets put out here, so yeah, one here, so it's made, we don't need to go through all the details, but you basically, it gets made, it comes out, we get exocytosis, and then we get, in the synapse, it's, oops, sorry, that's two there. So it attaches here, sorry, to the cholinergic receptor. So that's our muscarinic and nicotinic, which we'll talk about again soon. And then the acetylcholine gets broken down by acetylcholinesterase. Now, acetylcholinesterase can either be on the membrane or it can be separate, just floating around in the axon terminal. And that will, which is fine. There's just different types in different parts of the body. So that breaks up the acetate and the choline gets reabsorbed to make more acetylcholine. Okay, so that's normal acetylcholine secretion and reabsorption. That's how it works in the body normally. Now, so this is normal again. So we've got our acetylcholine coming out onto the receiving neuron. Acetylcholinesterase here is breaking it up and bits are getting reabsorbed, goes around. Okay, then this is our, essentially this is what we find in a cholinergic toxidrome. So as we said back here, oh, I can't find it, sorry. It's just a different name which is used in the US, but this picture I thought explained it quite well. So we're basically talking about the cholinergic toxidrome here. So what happens is your acetylcholine gets blocked. And so you get lots of the ACH agonists, receptor agonists, and that leads to a blockage of the ACH receptors. You end up getting basically this overstimulation of the receptors, and because your acetylcholinesterase is blocked, it cannot remove that off the neuron, and that's how you get problems. So with our cholinergic toxidrome, so our causative agents are insecticides, essentially. The biggest one that we sort of know about and talk about is organophosphates. You can also get it with chemical warfare and nerve agents, some of the dementia medications, which there's a bunch there, and some of the medications used in myasthenia gravis, which is a disease that's associated with dysfunction in the ACH pathway. So the big one that we often recognize is the organophosphates, but obviously the others are important to know about as well. So you have two different types of receptors. You've got muscarinic and nicotinic. So with your muscarinic, they are on your effector cells, so smooth muscle and exocrine glands. And you also have muscarinic in your CNS neurons, so nerve, to do with nerve impulses. Your nicotinic are on the ganglions, so you get adrenal gland secretion, which is your adrenaline and noradrenaline, striated muscle, so your muscle contraction, skeletal muscle contraction, and then CNS neurons as well. So when you see a cholinergic toxidrome, when you have, for example, exposure to organophosphates, these are the things that you may get. Now, these are two different mnemonics to remember. You don't have to remember both, you just want to remember one. So the biggest thing that you get, and these are the muscarinic effects, so again, going back, when we look at muscarinic, we're looking at our smooth muscle and exocrine gland. So we're looking at all our secretory areas, essentially, in the body. And that's why we get salivation, lacrimation, urination, defecation. It's all just this oversupply of secretions. You can get bronchuria and bronchospasm, so you just get secretions everywhere is the biggest thing to remember about the muscarinic effects. Obviously, like I say, there's a mnemonic, you can try and remember that. And then we'll talk about the nicotinic next. So remembering the nicotinic effects, we're talking about things in the ganglion and the adrenal gland, our striated muscle, and some of the CNS effects. So nicotinic effects, we get muscle weakness and fasciculation, so this overactivity of skeletal muscle. We get adrenal medullary activity. Now, the adrenal medulla is responsible for adrenaline, noradrenaline, and then our cortisol response as well. So you're basically going to get this hyperstimulation of your sympathetic nervous system. You're going to get lots and lots of circulating adrenaline and noradrenaline, which leads to your tachycardia and your hypertension. And your cramping is essentially because you've got that overactivity of your skeletal muscles. So, management. Obviously, one of the big things is going to be airway management. Of all those things that are secreting stuff everywhere, the biggest problem will be your airway, because if you have lots and lots of airway secretions, they might just need lots and lots of suctioning. Decontamination is important. So the one of these that I've seen, well, it was two patients, and it was they were cleaning up a banana tree field, I guess, is what you'd call it, up in North Queensland after Cyclone Yassi. Now, obviously, a lot of these places lots of farms use organophosphates, and the exposure is often accidental. So they were cleaning up after all the damage and didn't realize they were getting exposed to the organophosphates because they normally work on the farm anyway. So decontamination is important because it's often actual skin exposure that causes this with organophosphates. So sometimes people will swallow it in an attempt to kill themselves, but it's often accidental skin exposure. So removing their clothes or getting them to remove their clothes and washing them as best you can, even if it's just a brief wash. If they're well enough, you can just get them to have a quick shower. So they're the options. Atropine can be used to try and reduce those effects. So you may need backup for atropine. It should be available with any sort of critical care or intensive care paramedic in whatever service you're working in. Sometimes they do, if it's that bad, they might just need some sedation and intubation, but that's sort of dependent on the situation. Now, anticholinergic toxidrome. So anticholinergic agents competitively inhibit acetylcholine at the muscarinic receptors. So one of the important things about the anticholinergic toxidrome is it essentially only acts on the muscarinic receptors. So anticholinergic agents, although we call them anticholinergic, are essentially antimuscarinic. They only act on muscarinic receptors and they don't affect the nicotinic receptors. So muscarinic acetylcholine receptors are located in the smooth muscle, ciliary body of the eye, and our salivary and sweat glands, and in the CNS. They're not found at the neuromuscular junction, so skeletal muscle is all nicotinic, so we don't have to worry about that with anticholinergic. So there's lots of things that can cause it. So we've got anti-Parkinson's drugs, antitussives, antihistamines. So antihistamines are one of your more common ones, and your motion sickness agents that you might see. Obviously your antipsychotic agents in patients, so like to see this, it would be a patient that takes it regularly, so a schizophrenic patient or something like that who might be on something like chlorpromazine. You can see it with some of your bronchodilators, some of the antidepressants, anticonvulsants, etc. So there's lots and lots and lots of things that may cause an anticholinergic toxidrome. Okay, so this anticholinergic toxidrome is basically like, think of the opposite of the cholinergic. So everything's dried up, essentially. With the cholinergic, we have excessive excretion of everything, and in the anticholinergic, everything's dried up. So red as a beet, dry as a bone, blind as a bat, mad as a hatter, and hot as a hare is like the common saying. Essentially, they get dry skin, they get hyperthermic, they're thirsty, they've got a dry mouth, the pupils are dilated, tachycardic, urinary retention. It slows their gastric emptying, decreased bowel sounds, they can get delirium and hallucinations. So with the management of these patients, maintain their airway, breathing and circulation is obviously important. If they've got hypotension, you might want to give them fluid resus, manage their seizures if they have them, treat hypoglycemia if they have it, treat the hypothermia. So in these patients, antipyretics are unhelpful because what's happening is there's this overactivity of the smooth muscle from this constant oh gosh, sorry, I've like completely forgot my words. So the hypothermia is because of overactivity of the muscle. It's not due to thalamic resetting of the temperature. So antipyretics, when they act, you essentially get the COX pathways that act on the hypothalamus. So that's not going to help in these patients. So there's not really any point using paracetamol or Nurofen. They may get quite agitated and delirious, and sometimes they need sedation. The important thing with sedation, so it's with these patients, droperidol may worsen the symptoms. So as I have put back here, one of the causative agents, oops, sorry. So down here, one of the causative agents is droperidol. So we need to be really careful about giving droperidol to suspected anticholinergic toxidrome, and just use things like midazolam instead. Okay, sympathomimetic toxidrome. Now this is a really interesting one. So sympathetic agents are essentially things like we always think of amphetamines. Essentially, it's a good example. But one of the important things about the sympathomimetic toxidrome is that it's not drugs that mimic the physiological effects of stimulating the sympathetic nervous system. But it's also, it's in here. So it's not just the presence of having lots of one agent, it can also be the withdrawal of a sympathetic suppressant. So we'll talk about that more. So the effects of amphetamines or sympathomimetics are exerted by a number of mechanisms. So you get a blockade of monoamine reuptake transporters, displacement of the monoamines from the presynaptic vesicles, and displacement of monoamines from neuron cytosol by changing the cytosolic pH. So, methamphetamines lack the capacity to activate noradrenaline receptors directly. Most of the effects are exerted indirectly by displacing noradrenaline as well as the dopamine and serotonin from the presynaptic storage vesicles. So it often inactivates the catecholamine reuptake transporters, which increases the neurotransmitter presence in the synapse. So with toxicity, your cardiovascular effects are predominantly due to noradrenaline displacement. You get behavior alteration and psychotic symptoms, which are often due to the dopamine displacement. And serotonin is held responsible for mood alteration and bizarrely distorted responses to thirst and hunger. So, as I said before, it's not only the intoxication or the excessive use of sympathetic agents such as amphetamines, but it also can be withdrawn from sympathetic suppressants. So that's really important to remember. So we've obviously got amphetamines, cocaine, theophylline, which is rarely used. It's not seen regularly, but it is an asthma medication for people with really brittle or severe asthma. Caffeine, monoamine oxidase inhibitors, which are often used as an antidepressant. They're less common than some of the newer agents like the SSRIs or SNRIs, but they are still there. And then withdrawal from things like benzodiazepines and baclofen, which is an interesting one. So baclofen helps reduce muscle spasms in patients with things like cerebral palsy or post-stroke or traumatic brain injury. So controlling the agitation is the main clinical priority. If you control that, it also helps to ameliorate the cardiovascular effects and the risk of hemorrhagic stroke. So these are just some of the things that we see. So obviously it affects lots of different parts of the body. So we get our respiratory effects, so we get an increased respiratory rate, an increased minute volume. We sometimes get an irregular respiratory pattern. In terms of cardiovascular, they become tachycardic, hypertensive, ECG changes, which can be suggestive of coronary ischemia. They can definitely get chest pain and troponin rises, and it's often associated with demand. So it's because they've got such rapid heart rates that it is straining the heart muscle. And they get flushing, so they'll be red and they have brisk capillary refill. They can end up with rhabdomyolysis and then myoglobinuria, so it can damage the kidneys, and then they can get acute pre-renal failure, which is often due to dehydration. So they tend to, obviously with the fluids and electrolytes and endocrine, they tend to get very diaphoretic. They lose lots of fluids through their increased rest rate, they're sweating, so they definitely need lots of fluid replacement. And then they get a hyperkalemia secondary to fluid losses and metabolic acidosis. In terms of the neurological symptoms, they often present agitated, anxious, they may have hallucinations, acute psychosis, seizures, they can be hypothermic, and hyperreflexic as well. Good. Okay, so management. So as I said, they might need to be sedated for safe transport. Obviously control your seizures using midazolam, and attempt to control temperatures if their temperatures are above 39.5. As said before, similar sort of situation, antipyretics just won't help in this situation. So it's more about active cooling measures than anything else. Okay, so serotonin syndrome or serotonin toxidrome, it's often referred to as serotonin syndrome, but some people will call it a toxidrome as well. So it's a clinical manifestation of excess central and peripheral serotonergic neurotransmission. So basically just too much serotonin. It manifests as a wide variety of signs reflecting the triad of CNS, autonomic, and neuromuscular dysfunction. So there's a big spectrum ranging from mild symptoms to severe, as with most things. If the serotonin syndrome can occur, so it can happen in a number of different clinical settings, which is, again, important to understand. So it can be on the introduction or increase of a single serotonergic drug. So it can be a very unsuspecting thing. You know, it can just be one medication, one dose increase, that's it. It can be when you change from one serotonergic drug to another. So often when changing antidepressants from one to another, they need to have a washout period and they need to have reduced their dose and not taken it for a certain period of time before starting the next one. It can be drug interaction between two serotonergic agents. It can be interaction between serotonergic agents and then illicit drugs as well, or even herbal preparations. Can be deliberate self-poisoning or accidental ingestion. So, as we said before, so with these, like what we say is all of these drugs are serotonergic in some way. So they either upregulate the receptors, or they inhibit the reuptake, or they modulate the sensitivity, or something. So they all have some sort of effect on the way serotonin is used in the body, and to mean that there is more serotonin. So normally, often, like I said before, you can sometimes get it from just a simple one serotonergic agent, but it's less common. It's often when people combine more than one agent. So we've obviously got all of our different types of antidepressants, all have some effect on serotonin. Our sympathomimetic stimulants, again, we've got serotonin antagonists, so things like ondansetron, very commonly used. Other modulators, we've got herbs such as St. John's wort, which a lot of people use. Anti-migraine medications, some antibiotics. Now, linezolid is not super commonly used, and methylene blue, again, not commonly used, so it shouldn't necessarily be something you come across. But the main thing is lots of things can cause serotonin syndrome. Okay, so these are all the sort of symptoms that you tend to get, and there's lots of similarities with, like, definitely a crossover with your sympathomimetic toxidrome. So they get agitated, hypervigilant, they might have delirium. They get some more significant sort of motor symptoms. So they get clonus, which is essentially an inability for the muscle to sort of relax. So it's this ongoing contraction of the muscle. They can be tremulous or shivering and have hyperreflexia, hypertonia, and rigidity. And then they get diaphoretic, tachycardic, flushing, so pupillary response as well, and hypothermic. So this is just a good mnemonic of, remembering the main parts of serotonin syndrome. So in terms of management, so again, we manage our ABCs, we manage hyperthermia with active cooling if need be, and we manage dehydration, so they often will require fluids, and hyperreflexia and rigidity, so generally probably not something that you would necessarily need to do pre-hospitally, but they may need some sort of benzos and things like that to try and reduce the rigidity. Okay, opioid toxidromes or overdose. So the opioid toxidrome is essentially just what you learn about an opioid overdose. So patients get CNS depression, firstly, with opioids, it can either be intentional, so as we see with street drugs, with, whether they're using fentanyl or heroin or whatever they might have access to, and then we can also see it accidentally, particularly in older people. They may present with sort of opioid overdose symptoms, so it's important to remember and always check what medications patients are taking. So they present with CNS depression, hypoventilation, hypotension, pinpoint pupils. They may have nausea and vomiting, and they might aspirate, and it always gets better quickly with naloxone. One thing to be aware of, and sometimes where it won't get better quickly, is because these patients actually take polypharmacy overdoses. So you may see some improvements in some of the symptoms, but not all of them, and that might make you wonder what else they have taken. So in terms of management, obviously be aware of drug paraphernalia, especially if they're injecting, maintain airway and breathing. Try to give them as much oxygenation as you can prior to using naloxone. It can help to reduce their aggression when they wake up after naloxone. Use naloxone as per your protocols with the service you're working in, depending on your level and what service you're working in. It's often just a standard intramuscular dose, which is often quite a high dose, and naloxone will sort of then sit in the system for a while and can help to offset the opioid in the body for quite some time, just in case the patient absconds. And some services will allow you to titrate IV naloxone to effect. So basically getting the patient to the point where they're breathing on their own, they've got a good airway, and transporting them to hospital that way is always a good idea. Be really wary. So obviously you can produce a withdrawal in the opioid dependent patient. Now this is not the drug addict patient. It's really important to be aware. For example, some of the accidental overdoses you may see, such as a cancer patient, if they're taking high dose opioids because they've got really severe cancer pain and they're dying, and you give them high dose naloxone, all you're going to do is cause withdrawal and cause them severe pain. So in that situation, titrating naloxone to the point where they're breathing on their own is the best option, to try and avoid that withdrawal and severe pain, because then the naloxone is in the body for a while and opioids will then not work for their pain. It will be a very unpleasant experience for the patient. Just be aware you can obviously get other symptoms as well. Depending how long they've been on the ground, they may have seizures, which may be neurological, they may be hypoxic. There's lots of potential other injuries and things that can happen. Okay, now we're going to talk about some of the other overdoses. Okay, so benzodiazepines. So benzos are sedatives. They're involved in up to a third of deliberate self-poisonings, which is quite a high number. Isolated benzo overdose usually causes only mild sedation, irrespective of the dose. So that's one of the good things. Even with really high doses, we often pop these patients on their side and let them sleep it off. And they might sleep for days, but they will wake up. They very rarely require, airway management. Sometimes they do, and sometimes they may have vomited and aspirate, so they're important things. So they still need to be monitored while they sleep for days, but they don't necessarily need sort of intubation and ventilation. Sometimes they can present with other symptoms like hypothermia, hypotension, and bradycardia. The other thing that's important is the co-ingestion of other CNS depressants, so always asking if they've had alcohol or opioids or antidepressants, anything else. Basically, any polypharmacy overdose is worse, so we need to know about that. So onset of symptoms is usually within about 1 to 2 hours. Sometimes, obviously, if it's IV, it would be more rapid. They're often lethargic. They might be ataxic and have slurred speech, drowsiness, reduced responsiveness. And as I said before, profound coma is quite rare, but it will be more common in susceptible populations. So in terms of management, manage their ABCs. They might need some positioning of their airway. You can often place these patients in the left lateral and then just give them some neck extension to maintain their airway. If the patient's snoring, they need some airway positioning or support, and they might need respiratory support. Obviously, as I said before, if they've co-ingested with other medications, they may need some more aggressive management. Flumazenil, we have in hospital. It's not that commonly used. There's lots of sort of benzo, just diazepam overdoses, especially if they're oral, that flumazenil isn't really used. But it is something that's there. Okay, carbon monoxide. So the important thing about carbon monoxide is so it attaches to the hemoglobin, so you get carboxyhemoglobin, and it's a competitive binder. So it competitively binds and it binds at a rate about 200 times stronger than oxygen. So it basically displaces the oxygen off the hemoglobin. So if you have a suspected carbon monoxide poisoning, it competitively displaces the oxygen, and then you end up with a pulse oximetry that's reading high, but the patient is hypoxic. So it can be quite deceiving. They get cherry red skin, although it's often a late sign and it's not always present. So as I said, or the main problems with carbon monoxide poisoning are this hypoxia, and it's acute, severe hypoxia due to that competitive binding, and it often also leads to endovascular oxidative injury and inflammation as well. Oops. So first thing is to protect yourself and others. As always, remove the patient from the exposure. So, if this was an intentional attempt at suicide and they are, in a vehicle with, a pipe from the exhaust into the car, you need to get them out of the car. Basically just move them into fresh air, so out of the vehicle, out of the house, and that will alleviate the immediate sort of ongoing threat of the carbon monoxide. High flow, high dose oxygen, so as much oxygen as you can. So a non-rebreather mask, 15 litres a minute, and put that on and keep it on, and they need to keep it on. Obviously, if they're really unwell and you need to use other airway adjuncts or IPPB or anything like that, then as always, have 100% oxygen on there. Sometimes they might need hyperbaric oxygen, but that's definitely down the line. Okay, oral analgesics. So there's a couple of different ones. So the most important ones are salicylate. So aspirin is really important to know about in overdose, and paracetamol. So salicylates or aspirin can cause nausea and vomiting. They can get tinnitus and hearing problems and vertigo. And then it affects the CNS, and they get agitation and seizures, reduced ventilation, hypothermia, and they can have problems with their BSLs. So aspirin seems very sort of unassuming maybe, but they essentially end up with a high anion gap metabolic acidosis, and they get multi-system organ failure. So pre-hospitally, we want to manage ABCs. We want to allow a respiratory alkalosis. So if someone is breathing up, we want to allow that. We want them to be breathing, breathing up as much as they possibly can, to breathe off their CO2, or blow off their CO2. If they need ventilation, which we'll talk about here, but if they need ventilation, you want to continue to hyperventilate the patient. So you need to manage their dehydration with fluids, manage their hypothermia, and transport to a medical facility. Now, in hospital, activated charcoal is sometimes used, as is whole bowel irrigation. Hemodialysis can help to get rid of the salicylates in the blood. And then with intubation and ventilation, you need a high minute volume to maintain the respiratory alkalosis. So what happens is if you drop that and they end up with an acidosis, the salicylates are allowed into the CNS. So with a lower pH, the salicylates can cross the blood-brain barrier and cause a lot of problems in the central nervous system. Whereas if you maintain that respiratory alkalosis, it keeps the salicylates trapped in the bloodstream. Paracetamol. Now, paracetamol, it's obviously very common in overdose because it's very readily available. Paracetamol overdose leads to a depletion of the glutathione stores, and the body's then unable to convert intermediate toxic metabolites into non-toxic metabolites. So there's a threshold for possible hepatic injury. These are the thresholds. As I said before, call Poisons Info and just ask them. They're really, really good with advice for things like this. Trying to find, okay, it's back there. Okay, I have another slide that I couldn't quite work out where it was. So, obviously, basic care principles is normally absolutely fine. You're generally not going to see anything too significant from these patients in terms of you having to intervene. However, they do need to come to hospital. Paracetamol is often taken as part of a polypharmacy overdose, so that's important to be aware of. What other symptoms do they have? Are you worried there's something else on board as well? And they need to be reviewed in hospital. They need to have paracetamol levels, they need to have other blood tests done, they need to have a psych review. In hospital, we use N-acetylcysteine or NAC, which I'll go through in a little bit. And then there's high risk overdoses are really important. So the massive overdose, which is considered to be greater than 500 milligrams per kilo, extended release paracetamol is really bad. So your paracetamol osteo, because it has about 30% rapid release and 70% extended release. So these patients are at risk of ongoing liver damage for the next, however long, depending how much they've taken. And the other one is staggered overdoses. So the patient who's basically taken multiple overdoses, sort of smaller overdoses, but multiple over a couple of days, they're at high risk as well. Okay, so this is what happens in hospital. So we have this is called the paracetamol nomogram. What essentially happens, so patients who come in with a paracetamol overdose, the first thing is, what is the suspected dose that they've taken, and when did they take it? So if, for example, and this is one thing where even in hospital poisons is really, really useful, if a patient has taken 500 milligram tablets, and you can call poisons and say, they're 15 years old and they weigh 50 kilos and they've taken this much medication, they will give you advice. So generally, with a paracetamol overdose, the paracetamol level needs to be done at 4 hours. However, if this patient is considered to be a massive overdose, if they have any liver derangement initially, if they took a lot of extended release, or if they were like a staggered overdose over a couple of days, they will often tell you to start NAC straight away and then to go from there. If it doesn't meet any of those criteria, you need to do a 4-hour paracetamol level. So sometimes your paracetamol level, your first one will be at 10 hours, for example, if the patient didn't present till later. But if the patient comes in straight away at 4 hours, you do paracetamol level. Then what you do is, when you get your paracetamol level, most important thing is to work out which lab reporting you've got. So I think most of our labs reporting milligrams per litre. Whoopsies. So you use this side of the table and you compare your paracetamol level, or you plot your paracetamol level on the chart. So for example, at 10 hours, if our paracetamol level comes back at 90, so we come up here, that's our paracetamol level. It's above the nomogram line, and that means you need to start NAC treatment. If it is down here at 30, then you don't need to start NAC treatment. So a little bit about NAC. So when paracetamol is taken in large quantities, there's a minor metabolite called NACQI. I'm not even going to sort of pronounce all of this stuff. We just call it NACQI, which accumulates within the body. Now, normally it's conjugated by glutathione. So this happens anytime you take paracetamol, you produce NACQI. And glutathione normally conjugates it, but when you've taken paracetamol in excess, so you've taken a really large dose, your body's glutathione stores are not sufficient to deactivate all of the toxic NACQI. So it's then free to cruise around and damage your, it reacts with your hepatic enzymes and damages your liver cells, which can lead to severe liver damage and even death. So acetylcysteine, or NAC, acts to maintain or replenish the depleted glutathione reserves in the liver, and it enhances the non-toxic metabolism of paracetamol. So it's most effective in preventing or lessening hepatic injury when administered within 8 to 10 hours after overdose. Now, patients who get put on NAC for your information and interest's sake, patients in hospital who end up on NAC, different places use different protocols. There's a 2-bag protocol and a 3-bag protocol. So normally the first bag is over, I think normally the first bag's over 8 hours and then the second bag's over about 16 hours. And lots of the hospitals, I think now, are on 3-bag protocols, and you normally run the protocol. If they have had one level above the nomogram, you run the protocol. Often I talk to poisons and get their advice about continuing. If you then want to look at stopping NAC, what you need to do is the patient needs to have a paracetamol level less than 10. Their INR, so their coagulation studies, need to be normalized, and that is important because the synthetic function of the liver is to produce coagulation, parts of your coagulation cascade. So if your INR is high, then you've got obvious liver damage. And your transaminases, so ALT, AST, they need to have risen and peaked and have fallen and have evidence of them falling on 2 subsequent blood tests, and the patient needs to be asymptomatic for you to then be able to stop NAC. So sometimes the NAC may go for a week, or sometimes it's just the 3-bag protocol. And then obviously after that they end up with psych review and things like that. Now, iron. So iron, obviously, it's really common. It's a really common thing found in homes. Lots of people are on iron. Lots of women, when they're pregnant, are iron deficient, so they have iron at home. There's lots of different formulations, and in iron poisoning, the important consideration is the amount of elemental iron that's been ingested, so not the amount of iron salts. This is just a bit of a guide of how much elemental iron is in each of the sort of supplement types. Again, like I've said before, but definitely my recommendation for iron would be to talk to Poisons Info, because they will be able to give you much better advice. And if you've got the name, if you've got the bottle, you can tell them exactly, you know, what the bottle says, and they can work it out for you. So generally, ingestion of more than 40 milligrams per kilo of elemental iron they need to be assessed. If any, this is particularly children, but ingestion of an unknown quantity and any symptomatic children. So iron is a little bit unassuming in overdose, and I think it's probably not recognized for the severity of symptoms that it can cause, but it can cause really severe symptoms and can lead to some really severe problems and sort of multi-organ failure. So there's a bit of a sort of triphasic process that happens with iron overdose as well. So in the initial phase, they might get nausea, vomiting, diarrhea, abdominal pain, some hypotension, hematemesis, fever. It's all very general. They might get some GI symptoms, and if you have no symptoms in the first 6 hours, they're less likely to be significantly sort of have a significant toxicity. Then there's a bit of a latent period. So it's often 6 to 24-hour period where initial symptoms resolve before you get onset of severe symptoms. So that's why iron can be very deceiving. We sort of think maybe they're better, maybe there's nothing wrong, but that's not necessarily true. So then usually around any time between 6 and 24 hours and lasting for 12 to 24 hours, you get these other severe symptoms. So you get cardiovascular symptoms, tachycardia, vasoconstriction, hypotension, shock. They get a metabolic acidosis. They get big fluid shifts from intravascular to extravascular compartments and cellular hypoxia. This can all lead to multi-organ failure, particularly hepatic failure. So iron can be really, really bad. So almost anyone who's taken iron, but particularly it's one of those things that you might hear in kids, they definitely need to be assessed in hospital. So obviously management, pre-hospitally, there's symptomatic treatment for whatever you find. Just have a high suspicion and then transport for further investigation and management. In hospital, there is sometimes they do whole bowel irrigation. So if the suspicion of like taking a lot of iron is high, they may do abdominal x-ray, which can see the iron tablets, and then they might look at doing whole bowel irrigation. And then there's a chelating agent, desferrioxamine, which forms a water-soluble desferrioxamine iron complex, and that then gets excreted by the body. Okay, so our hypoglycemic agents. So everyone knows, obviously, insulin. We've got sulfonylureas, biguanides, all sorts of different oral hypoglycemic agents nowadays. So insulin, obviously, someone injects lots of insulin, they're going to be hypoglycemic, and it's going to be persistent because they've got this big amount of insulin, particularly if it's like if you have, I mean, it can happen with obviously either rapid acting or slow acting, but they'll have basically this big amount sitting in the subcutaneous tissue. So it's just this ongoing persistent hypoglycemia. And obviously persistent hypoglycemia can lead to really severe neurological injury. So they get a hypoglycemic hypoxic brain injury, and it can cause permanent disability. Now, different sulfonylureas can obviously cause hypoglycemia. Biguanides often have a delayed onset of severe lactic acidosis, and some of the newer agents, the SGLT2 inhibitors, can cause a euglycemic ketoacidosis, so they're a bit deceiving. Now, obviously, the biggest things to be aware of, or you know, our guiding principles, is managing our ABCs first, and manage the hypoglycemia. So as per your guidelines, using your 5% dex as you can and need to. Particularly if you've got longer transports, or if it's something where you think you're going to need ongoing, and I'm not sure if it's available in any of the services, but we do have up to 50% dextrose, which can be used. But again, like I say, I'm just not sure in your environments if that's available. But if you know that it is, using sort of CCP backup for 50% dextrose would be a good idea. Okay, so cardiovascular drugs, there's three sort of groups we're going to talk about. We'll talk about the beta blockers, the calcium channel blockers, and digoxin or digitalis. Okay, so our beta blockers are competitive antagonists to the beta 1 and beta 2 receptors. So beta blocker overdose is potentially fatal because of their cardiovascular effects. Now, sotalol and propranolol are considered more toxic. So propranolol crosses the blood-brain barrier and has a sodium channel blocking effect, which lowers your seizure threshold, so you're more likely to have patients having seizures. And sotalol is a really potent cardiodepressant. So sometimes it just leads directly to an asystolic arrest, and they can also get prolonged QT and torsades. So clinical features. So you'll often, they might get PR prolongation, which is often early, bradycardia, and they'll have sort of dysrhythmias and all sorts of weird and wonderful bradycardic type rhythms. So sinus bradycardia, you can have anything from first to third degree heart block, junctional rhythms, idioventricular rhythms. Hypotension, delirium, coma, you can have seizures, you can get things like bronchospasm, and then obviously your hypo and hypoglycemia is important for you guys. Hypokalemia, you're not going to know about anyway unless there's obvious ECG changes. So obviously, again, we want to manage our ABCs, manage hypotension, so you can trial fluids, and then you want CCP backup. So the thing that's really difficult with beta blockers, and again with calcium channel blockers when we talk about those, is that the way, particularly as you know, things like atropine and adrenaline need our beta receptors to produce the effects that we want. So if you've got an overdose of beta blockers, they're already blocking all the receptors. So using atropine and adrenaline for heart block is not going to work. So the management principles have been developed based on bypassing those pathways. So Ways to bypass the pathway. So using high-dose IV glucagon has been done in the past, and that's probably the best option pre-hospitally as something that can be trialed, and it may or may not help, but you need a lot. So you really need basically all the glucagon you have in your truck, probably at least someone else's truck as well. So that's something that can be trialed. And then in hospital, our mainstay of treatment is high dose insulin, and it's really, really, really high dose insulin. So we obviously have to put dextrose with it to make sure that they don't become hypoglycemic. But insulin has, there's some parts of it that sort of seem to bypass the pathway, but other parts of insulin are actually have a vasoconstrictive and inotropic effect, so they help to increase the heart rate, increase vasoconstriction, and overcome some of those issues with the blockade of the overdose. And obviously urgent transfer. Now, calcium channel blockers prevent the opening of the L-type calcium channels, so it results in decreased calcium influx, leads to smooth muscle relaxation, slows cardiac conduction, reduces the force of myocardial contraction. Now, verapamil and diltiazem are commonly cause cardiovascular collapse in overdose, and that's because they have central cardiac effects and peripheral vasodilation. So, you often get hypotension, bradycardia with your verapamil and diltiazem, and tachycardia with your dihydropyridines, so some of your other calcium channel blockers. You'll get a prolonged PR interval, and you can often have heart block. You get hypoinsulinemia, and that's because the insulin release in the body is regulated by calcium entry into the islet beta cells via L-type channels. So that's quite important. You can get insulin resistance and hyperglycemia. So in beta blocker overdose, it's normally hypoglycemia, but calcium channel blocker overdose, it's hyperglycemia. Impaired cardiac fatty acid metabolism, so the heart muscle uses fatty acid metabolism for energy, and it forces a switch to the use of carbohydrates for energy. Then you can get some other extracirculatory effects. So management principles again, ABCs, hypotension, manage that with fluids and similar sorts of things. So adrenaline and atropine just won't work. You can trial IV glucagon if that's something within your scope of practice, but essentially they need urgent transfer to hospital because they need insulin dextrose infusion. So this is just a case, so you're called to a 60-year-old male unconscious patient. The patient was found by his daughter, who spoke with the patient on the phone about 2 hours ago, and she was concerned when he failed to answer the phone. So on your arrival, he's unresponsive, his airway is clear, he's breathing at a rate of 12 per minute, and his saturation's 94 on room air. His pulse is 30 per minute, and his blood pressure is 70 on 40. He's currently GCS 3, he's got a BSL of 8, and his pupils are mid-size and reactive. So this is your rhythm strip. So, I mean, you can think about this yourselves. If you're listening, if you're in a group, you can discuss the priorities in this case and sort of see what you think the important things are that needs to be done, and what are the possible causation of this patient's condition. So when you look at his past medical history, he's got a history of hypertension, angina, and his wife recently died. And there's an empty packet of isopten, which is verapamil, I believe, when I looked it up, but you might want to double check. Always just Google medications if you're not sure, if you can't find it on the packet. And there was a packet of 100 dispensed yesterday, and it's found next to the patient. So again, we've got this extra information. What's the likely cause? What's the management priorities? So then the patient has a brief tonic-clonic seizure, and then you get this rhythm on your rhythm strip. What will you do now? So, patient suffering from a calcium channel blocker overdose. So, I think it'll be worthwhile, even if you're on your own or if you're in groups, go through and try to answer those questions that are there. Obviously, I've told you it's a calcium channel blocker overdose, but I think try and think of it as an exam question. How would you answer that in an exam? How will you manage this patient? Okay, digoxin. So, digoxin is a cardiac glycoside steroid. It's got a really long half-life, so 30 to 40 hours, and it's a potent and highly specific inhibitor of the sodium-potassium ATPase pumps. So the mechanism is of positive inotropy, which involves an altered balance between the intracellular sodium and calcium. When it's at therapeutic levels, it decreases automaticity and increases maximum diastolic potential. And when it's toxic, it does the reverse. So it increases automaticity and decreases diastolic potential. Now, decreasing the automaticity, this is important because we often use digoxin in rapid AF. So we're trying to control their arrhythmia with it. So one of the important things about digoxin, I think it comes up. Oh, wait. Oops. So, things that it can cause. So bradycardia, AV block, ventricular ectopics, tachyarrhythmias. You can basically have any type of anything, basically. You can get this bidirectional ventricular tachycardia, which is really, really rare, but digoxin is one of the drugs that can actually do it. And sometimes cardioversion is quite difficult. I'll show you the next ECG, which you just saw a minute ago, which is really ugly looking, is this bidirectional ventricular tachycardia. So then non-cardiac, you can get nausea, vomiting, abdominal pain, diarrhea, weakness, confusion. They can see yellow, which is interesting. And they can get hyperkalemia because of the inhibition of the sodium-potassium ATPase pump. So this is that bidirectional ventricular tachycardia. It looks horrendous. Guiding principles, obviously manage your ABCs, consider backup if you've got some nasty looking arrhythmias. The patient needs urgent transfer to a facility that has digoxin specific fragments, or sometimes it's called digibind. So it's an immune complex which binds to digoxin that is then filtered by the glomeruli in the kidneys and then reabsorbed in the proximal tubules while the digoxin is excreted. So it helps to excrete digoxin out of the system. It's really important to consider. So digoxin has quite a narrow therapeutic window, but we don't really monitor it. And so patients who become unwell, possibly for another reason, who are on digoxin, it's really important to consider digoxin toxicity as a possible cause. So, a patient who's been unwell with vomiting and diarrhea, who's now got some other symptoms and maybe has some arrhythmias and is known to be on digoxin, just think about digoxin toxicity. Okay, now we've got our SSRIs. So SSRIs, overdose is quite common. So SSRIs, our selective serotonin reuptake inhibitors, they're a really common antidepressant. The overdose is common, but it's usually quite benign. They may get some serotonin toxicity type symptoms, but often it's very sort of mild. They can have seizures, which is heralded by these sorts of symptoms here. And obviously, if they've co-ingested with other serotonergic agents, then you might worry about serotonin syndrome more. So drugs in this group, as some of them are below, again, like I said, without sounding like it sounds stupid to Google things, but no one's ever going to remember all these different medications, and sometimes the boxes don't have the names on them, or they might have the name, but you have never seen paroxetine before, and so to double check what type of medication that is, you can just Google it. That's why we have smartphones. So obviously guiding principles is essentially just management of ABCs, manage their seizures if they have them, and manage any clinical effects of serotonin syndrome that you might see. Okay, so then we've got our serotonin and noradrenaline, so our SNRIs. They're a similar medication, but obviously acting slightly differently, but still affecting our neurotransmitters. So things like venlafaxine and desvenlafaxine are probably the two commonest that you'll see. There is a higher potential for life-threatening consequences. So about 14% of patients have seizures, but it's often dose-related. So the higher the dose, the more likely they are to have seizures. The potential for serotonin syndrome is increased, and again, particularly if there's other serotonergic agents that are involved. So manage ABCs, manage seizures, consider CCP backup if there's agitation or dysrhythmias, active cooling if they're hypothermic, manage hypertension. Tricyclics. Now, tricyclics is one that we always like to talk about when we're talking about overdoses. Tricyclic antidepressants are an older antidepressant. They are much less common in the community now. However, there's probably been a more recent increase in their use again. So SSRIs and SNRIs are much more commonly used for depression and anxiety. However, tricyclic antidepressants may be used for depression and anxiety. They may be used for other things. Some people are on tricyclic antidepressants for chronic pain or nerve pain, things like that. So they're, as I said, less common. Ingestion of 10 to 20 milligrams per kilo is potentially life-threatening, and the onset of toxicity usually occurs within 1 to 2 hours. So there's 4 main toxicological features. There's a sodium channel blockade, which causes QRS prolongation. You get alpha-1 receptor blockade and hypotension. Anticholinergic toxidrome, so they get tachycardia and delirium, and they get antihistamine-related sedation. So tricyclic antidepressants are quite dirty drugs, and they affect lots of different sort of neurotransmitters and things in the body. So managing our ABCs, if you need to manage their airway, then hyperventilation helps to produce a respiratory alkalosis, and alkalosis increases the protein binding of TCAs in the blood. Treat as time critical due to potential for rapid deterioration, and ask for backup. Treat seizures if they happen, monitor cardiac activity, IV access and fluids if necessary, sodium bicarbonate. So you may want that for management of prolonged QT. If the patient arrests, cardioversion and defibrillation may be refractory, so they often have prolonged QT, which leads to torsades, and without management of the underlying causes, they won't necessarily revert with defibrillation. Okay, so we've got some of the ECGs here. So this ECG is showing sinus tachycardia with a first degree AV block, and it's got here the P waves are hidden in the T waves, but it's best seen if you look in B1 and B2. We've got broad QRS complexes, which you can see there, and we've got a positive R wave here, which you can see in AVR. So this is worsening TCA toxicity. So I believe this was supposed to be the same patient as their toxicity is worsening. And it shows cardiotoxicity with marked QRS broadening, which you can see, producing, which is essentially a sine wave. So when you look down here and leave 2, you get this sine wave appearance. Okay, corrosives. So corrosives can cause injury to the upper airway tract and the gastrointestinal tract. The upper airway injury is potentially life-threatening, and you can get severe GI tract injury. Now, things that we worry about is stridor, drooling, vomiting. Just because they don't have lip or oral burns does not exclude that they've got more internal burns. So again, and I'll say it first, it's down the bottom here, but call poisons. There's so many things out there that, you know, none of us would know from a bar of soap whether they're going to be poisonous or not, but we've got so many household items and so many things if you're working in agricultural areas that people may ingest or be exposed to. And the best thing to do is just call poisons and ask. Because a lot of the time they'll tell you it's absolutely fine, it's not toxic, they can even stay at home. And other times they'll be able to give you advice on what to do, whether they should eat or shouldn't eat, whether they should drink or shouldn't drink, you know, things like that. So call poisons. You can wash their mouth out. It's best to not give them any oral fluids, not to induce vomiting, and just transport them as quick as possible to hospital. Paraquat poisoning. So paraquat is a widely used herbicide. It's potentially lethal following ingestion as little as a mouthful, so it's really quite potent. And it often results, if they do have toxicity, it results in fulminating multi-organ failure, so it's quite nasty. They often present with signs of oral burns or gastrointestinal signs and symptoms. So toxicity emerges in several discrete phases. So phase 1 is corrosion, mucosal lining ulceration and swelling. There might be hematemesis, so this is in the first few days. Phase 2 is organ failure. So between the 2nd and 5th days following ingestion, there's renal failure, hepatocellular necrosis develops. Most patients with severe overdose will die during this phase. And then phase 3 causes pulmonary fibrosis and death after days or weeks of hypoxia. So as I said before, it's really, really quite nasty. And obviously, it's also not super quick if they die. So even these people who die from multi-organ failure sometimes might last for like 5 days, which is pretty awful. Acute fulminant toxicity can occur and progress straight towards death over several hours. So that's a lot higher doses. So main things: don't induce vomiting. If they've got things on their body, try and decontaminate, so remove clothing, wash the skin with soap and water. Now, there's always this talk about withholding oxygen. So it's important, the uptake of paraquat is highest in areas with high oxygenation. So the lungs have really high oxygenation. And if you give more oxygenation, you exacerbate the oxidative injury or toxicity of the paraquat. So you get more oxidative injury in the lungs the more oxygen you give. So if patients are maintaining their saturations over 90, try and avoid oxygen. If they desaturate less than 90, then you probably want to discuss it with someone, but you can consider supplemental oxygen to maintain their saturations around 90. And they need to be transported really rapidly. The absorption is super, super rapid, so they need to be in a hospital as soon as possible. Now, glyphosate is another herbicide found in Roundup, so really common. It can cause corrosive symptoms, upper airway complications, because you can get oropharyngeal, corrosive injury. They can get aspiration pneumonitis and pulmonary edema, myocardial depression, and hypotension. So they can lead to multi-organ failure and metabolic acidosis as well. They need urgent transfer to hospital if symptomatic. And they may need fluid replacement to maintain this perfusion. Now, hydrocarbons. So this includes petroleum, kerosene, turpentine, some essential oils, things like eucalyptus. So things that are just around the house, again, your essential oils. So there's all sorts of sort of volatile substances. But patients often have immediate coughing and gagging. Be really wary, again, like I say, the essential oils. Kids, you know, find things in the house, and there might be essential oils for, you know, things around the house, and they might be the ones that sort of try and drink some. They can develop sort of lung symptoms, so wheeze, tachycardia, hypoxia, hemoptysis, and pulmonary edema, dysrhythmias, CNS depression and coma. They can have seizures, ataxia, nausea, and vomiting. So obviously remove the patient from the source, particularly if it's inhaled. If they're agitated, try and calm them down. try not to induce vomiting, provide oxygen and bronchodilators if there's bronchospasm present, and manage seizures as per you normally would with seizures, and backup for dysrhythmias. If you've got dysrhythmias, then you definitely want some assistance. Now, cyanide. So cyanide is obviously a chemical warfare sort of agent, but it's also a byproduct of the combustion of many modern sort of items that you'll find in a home. So if there's a house fire, you need to think about carbon monoxide poisoning and cyanide poisoning. So you want to support their ABCs, and there is an antidote, which is essentially vitamin B12 hydroxycobalamin. It is often available in injections in countries where there is high potential for chemical warfare, but if not available pre-hospitally here, you can definitely get it in hospital. That's that. So just a little bit about recreational drugs. So obviously a lot of these fit into some of our toxidromes. We've obviously got our depressants, which fit into our opioid toxidrome. We've got our stimulants, which fit into our sympathomimetic toxidrome, and then we've got our hallucinogenics. So we're not going to talk a lot about these. There's obviously lots of different types of things. You tend to get, the hallucinogenics tend to cause a sort of almost sympathomimetic and serotonergic type toxidrome. These are obviously all the novel drugs and different things. These things are changing all the time. There are so many synthetic agents on the market that cause different subsets of these symptoms or toxidromes, that basically most of the management is symptomatic and transfer them to hospital. There's a lot of research that gets done on any overdoses. Obviously, blood tests get taken, and there's been a lot of research, and they're showing that there's so many new synthetic agents on the market that research is often 6 months behind, even working out what those drugs are, let alone then knowing what to do with it. So one of the the main one I'm going to talk about is fantasy, or GHB. So there's lots of different sort of names for it. So it's often essentially just a liquid. It can be stored as a powder. It can cause rapid onset of neurological and respiratory depression. They can get myoclonic jerking. Overdose can be life-threatening without support of the airway and ventilation. And co-ingestion of other CNS depressants increases the risk of respiratory depression, apnea, and death, obviously. One of the things about GHB is it's often really atypical, and patients often have really alternating mental status. So for example, a fantasy overdose patient that I have seen was a patient who had a history of epilepsy, who took some fantasy, had a seizure, so the ambulance got contacted, and when we transported the patient, the patient was 1 minute was agitated and fighting and didn't know where he was and wanted to get out and was really, really strong and was really difficult to manage, and the next minute he was completely unconscious, GCS3, needed airway management, and then he would wake up and talk to us pleasantly like a normal person, and this cycled around and around. So it can be quite difficult to sort of manage, because obviously when they're fighting you can't have a tube or like intubate them without sedation, but when they become GCS3, they're really proper GCS3 and they need airway management. So they're quite difficult to manage. So here's some of the other clinical features. And again, with our management, it's ABCs, airway maintenance. So sometimes you might need to position them, you might need some adjuncts, you might need to ventilate them, manage seizures if they have them. Okay, so in summary, the main thing is managing airway, breathing and circulation, and continuous monitoring of vital signs. Symptomatic management is really important. So as I've said, with lots of these overdoses and toxidromes, lots of them can present with seizures, but it doesn't necessarily mean they'll have one. If they do, manage the seizure. Anything else, just manage symptomatically. Otherwise, making sure you're careful with your risk assessment and making sure that you're safe. In self-poisonings, we obviously have to manage the initial concern, but the primary complaint is underlying, but that gets dealt with at a later time in hospital. So questions, obviously, again, apologies for not being there in person, but if anyone has any questions, I'm sure you'll be able to get them to me and I can try and answer them as best possible. Anyway, thanks for listening. I hope you learnt something.